We will conclude this session with another important issue. Dr. Hawari, ممكن تقدم.
Okay, then my last talk today is the use of anticoagulants in hypertension. Well, the question is very, very important, that this is an issue that you confront every day in the clinic. But if I attend to the title, I can summarize my talk in this slide. The use of anticoagulants in hypertension patients. Many patients requiring antiaggregants or anticoagulants will be hypertensive. And in this case, if you need anticoagulant treatment, and the treatment is mandatory, because I'm going to comment that some of the that situations, you need to maintain blood pressure below 130. If you need to put anticoagulant treatment, but the intervention is not mandatory, if not depend of the risk, then the same. But you need to assess the risk first at the time to start the treatment. And of course, if you are using anti-aggregant therapy in prevention in lower risk subjects, of course, the blood goals as those that I have commented before, that recommended the European Society of Hypertension guidelines. But go a little bit more in deep. The most common complication, I say that the majority of subjects that are going to receive anticoagulants are hypertensive because they have usually people a little bit aged with a lot of pathologies that will be venous, the hair, embolus from the hair, arterial lesions, and the most common complication of hypertension are related to thrombosis. Hypertension is a prothrombotic state that can impact in peripheral vascular disease, heart failure, atrial fibrillation, as such has been commented. And of course, hypertension is not a contraindication, but you need to consider the risk of intracerebral hemorrhage. And effort should be directed toward achieving a blood pressure below 130/80 in patients receiving oral anticoagulants. If you needed a treatment mandatory, of course, you need to try to adjust as much as possible, and you need to put the treatment because the treatment is going to save life. But if the risk is risk dependent, you need to be careful and you need to select carefully what are going to do. Just only simple picture about what is the coagulation process that have the initiation, the amplification, and propagation, and then what are the drugs that we have right now. Maybe we are going to speak about this area, that those are the oral anticoagulants. Oral anticoagulants, we indirect, the antagonist of vitamin K, the direct, that are the thrombin inhibitors and the factors 10 activated inhibitors, and the other that this is parenteral, but that's also indirect, that this is the unfractionated heparin, low weight heparin, fondaparinux, are those the tools that we have in our hands. And then just to remember that the targets of the vitamin antagonist of vitamin K are in the initiation and in the first stage of amplification, that the targets of heparin is in the amplification, and the majority of the actions is the amplifications in the part of amplification, that only there is one antithrombin direct, that this is dabigatran. Then we have several possibilities. But of course, we have several clinical conditions in which we need to consider. If we have a patient hypertension with atherosclerosis, that this is a prothrombotic state, you need to do prevention, and antiaggregant, antiplatelet therapy is recommended in secondary prevention, and in primary prevention only in those with very high risk. And then the blood pressure to be maintained is more or less the same. And then here, the recommendations of antiaggregation for the guidelines is that antiplatelet therapy, in particular low-dose aspirin, is recommended for secondary prevention. For primary prevention, in hypertensive patients provide beneficial reduction in myocardial infarction in patients at high risk or those with reduced renal function, according to the whole trial time ago. And it is not recommended in low to moderate risk hypertensive patients who the balance between absolute benefit and harms is uncertain. What about acute coronary syndrome? In the acute coronary syndrome, in the treatment, after the thrombolysis or the anticoagulation, it need to be considered that the bleeding risk start the beginning, but is more prolonged than the risk of thrombosis. And then in this case, I am not sure if go below 130 is the best condition, because if not, you are going maybe to reduce the blood pressure too much. What about ischemic stroke? Here, we need to consider that when you have a patient with ischemic stroke that need to go to thrombolysis, blood pressure should be maintained below 180 over 105. If the patient is not going to thrombolysis, the levels of these are not required antihypertensive treatment in the first 24 hours. Of course, after, if they receive thrombolysis, you need to maintain blood pressure and reduce progressively in the following days. What about, well, this is what the guidelines say about this, that in acute ischemic stroke, I repeat, what are eligible for intravenous thrombolysis, blood pressure should be carefully lowered and maintained below 180 or 105 millimeters of mercury for at least the first 24 hours after thrombolysis. What about heart failure and valvular disease? In this case, you need sometimes anticoagulant in advanced stage of heart failure, in valvular prosthesis and valvular reasons from atrial fibrillation, that I am going to comment a little bit more about atrial fibrillation. And the blood pressure should be maintained below 130/80 as a recommendation. Atrial fibrillation has been presented perfectly for the previous speaker. Hypertension, it is a very, very important factor, causal factor to induce atrial fibrillation for several mechanisms that this is not the moment to comment, because it is a mix of that sympathetic activation of the renal system, and mainly fibrosis. But what about the anticoagulant? The anticoagulant should be based in risk score, and the blood pressure should be maintained below 140/90. I think at the beginning to do in this. And the recommendations of the Hypertension Society is a stroke prevention with oral anticoagulants recommended in patients with atrial fibrillation and hypertension, and Wachat-Bask score equal or 2 in men and in women. But there are another recommendation that is less strong, but can be considered. In those subjects that have a Wachat-Bask score, the 1 should be considered if the only factor is hypertension. If hypertension as the single additional factor. The oral anticoagulant should be used with caution, and then, of course, to try to lower blood pressure below 140, and initially below 140, don't like it. In the follow-up, yes, but not at the first moments that you start. Of course, what you need to do, those two possibilities, to use the vitamin K or the direct oral anticoagulants. In general, there is an advantage of the use of these DOACs in terms to reduce mainly hemorrhagic stroke and also gastrointestinal bleeding. But this is what you obtain in the trials. What about in real life? These are data from our clinic. It's 153,000 patients with atrial fibrillation, followed by 5 years, and 83% of them were hypertensives. Therefore, you will see here what happened with the treatments. This is until 2016. Then the use of DOACs is less, but of course you will see here that a large proportion of subjects and this is on electronic health recordings of the general population, in other words, real world, still without treatment. And some pass to lose the treatment. In those treated with antagonists of vitamin K, the DOACs or a mixed group of which they use heparins and so on. But you see here the risk for stroke. The risk for stroke is huge. The vitamin K antagonists, but even the DOAC, are those that reduce more, reduce at least 3-4 times the risk in these patients that, as I told you before, 83% are hypertensives. And finally, deep venous thrombosis and pulmonary embolism. This is a very common. This is in our clinic. We see in our hospital, we see all the pulmonary embolisms and deep venous thrombosis. Anticoagulant is mandatory, at least in those with at least 4 to 6 months. Thereafter, if you maintain, depends of the residual risk of predisposing causation. In this case, hypertension is not a risk condition directly, but blood pressure should be maintained below 140/90 due to the risk of intracranial bleeding. And then, to finish, I back to my first slide. Many patients that require to use anticoagulants and antiaggregants will be hypertensive. And then, of course, they need to control blood pressure because the risk of intracranial hemorrhage is increased, and also gastric hemorrhage, even less. But if you need to treatment because it's mandatory in order to reduce the risk of the disease that is producing damage, and then you need to anticoagulation, then try to maintain in these levels. If it is for prevention, you need to consider that these subjects are really high risk, because if you are giving anticoagulants, you are increasing the risk of our hypertensives, because we can maintain blood pressure below. But you need to consider that in hypertensives, the damage that is in the vessels is coming from many years. And then there are vessels that have more risk to have problems with that leakage and hemorrhage. And of course, it is a lower risk with prevention. Antiaggregants need to be think carefully, and then in those with prothrombotic states, that hypertension is one prothrombotic stage, only in high risk need to be treated. Thank you very much for your attention.
Thank you, Dr. Redon. I think the slogan of this presentation is that hypertension is a prothrombotic state. And we have
of course. No question.
Sorry?
No question, it's good, it's true.
Yeah. Because many physicians actually, when they found the hypertensive patient and there is indication of anticoagulant, the main issue in his mind that he is fear of hemorrhage. But
yeah.
It's important to as a precaution, but the most important, as you explained, that this patient is high-risk patient for thromboembolic events, whatever arterial or venous. Any question from the or comments from Dr. Tariq Zawawi, تفضل. We have question from Professor Tariq Zawawi.
Thank you for the presentation. My question about this point about the hypertension is considered as an inflammatory disease and pro-coagulant state. And the recommendation in patients, when we risk stratify our patients, if the patient is very high risk or high risk and already developed cardiovascular disease or target organ damage, the guidelines recommend aspirin class 2A. Is there any rule for a small dose oral anticoagulation like rivaroxaban or apixaban? This is
for prevention, no. For prevention, I think that the use of DOACs is not recommended anytime. You need only antiaggregation, not anticoagulation.
The second question, the hypertension is in patients with atrial fibrillation is considered risk for thrombosis and risk for hemorrhage. يعني for the has bled risk put 1 score, and for the thrombotic risk put 1 score. How to balance between these risks?
Okay, that's the balance is it's clear. If you have a chest mask 1 by hypertension, but you have a has bled high, maybe you need to be more conservative and use antiplatelet drugs. It's not the best, but in chest mask 1 and high bled high, of course you need to be careful. But if you have chest mask 2 or more, then you need to anticoagulate and try to control with a dose, at least that the drugs, when you use DOACs for prevention in atrial fibrillation, you need to use the dose that correspond. If you go down with very low dose of DOACs is useful for after surgery and to avoid deep venous thrombosis and then, but not to prevent that stroke for one atrial fibrillation.
Thank you.
Okay, we have another question, Dr. Samir.
We not infrequently we see patients with stroke with atrial fibrillation, and the neurologist give clopidogrel. How to combine clopidogrel with the anticoagulants, for how long and what dose? Any change in the dose, or sufficient to give for 1 month clopidogrel and then continue anticoagulants?
Well, I suppose that you are speaking that in subject that has been one intravascular stent that has been included, even for in the terms of coronary, that at the time to combine one antiplatelet with the anticoagulation. Then in this case, of course, that if you have one stent, one intravascular, it is recommended for 1 year to maintain the antiaggregation. The anticoagulation is shorter. But from time to time is given the possibility even to combine 2 antiplatelet drugs that with the first part of anticoagulation. But this is one thing that is moving today in the coronary heart disease.
Okay,
in patients after PCI.
I will take the answer for stent as for stroke.
Dr. Sobhi, another question.
Yeah.
Dr. Sobhi.
Thank you for this wonderful lecture. Actually, regarding your slides about the stroke and thrombolysis, acute stroke and thrombolysis, and the blood pressure, can you explain it again? Because in our country, there is debate between the neurologist and cardiologist. A neurologist doesn't agree about immediate thrombolysis if there is a high blood pressure. So can you confirm the finding now, because we have a lot of internists here together with the cardiologist. Can you get to please statement number 1, number 2, number 3? Okay, please.
Yeah. Well, if you have an ischemic stroke, that of course thrombolysis is indicated if it's in the period that you are on time, that is in recent. If the patients have a hypertension that is higher than 180, 105, is not recommended to start the thrombolysis until that the blood pressure is below these levels, 180 over 105. If the patient is not going to receive thrombolysis, even that the blood pressure is higher, is 200, it's recommended not to use antihypertensive drugs, even that is not higher than 220 in the first 24 hours. But if for thrombolysis, the blood pressure should be reduced below 180 over 105.
Okay, we have another question from the audience. Please come to the microphone.
Okay, I'm Ram Munir, a cardiologist. Please, if there is a case with an ischemic stroke and at the same time the patient is atrial fibrillation and his blood pressure not so high, maybe it's 150 over 80 or something like that, it's not high. And acutely in the ICU or in the CCU, he became in hemorrhagic transformation of this stroke. How to
Well,
deal with the anticoagulation in that situation, and when I restart.
Of course, you need data to avoid anticoagulation. If there is a transformation in hemorrhagic stroke, after thrombolysis, as you commented, or spontaneously?
Spontaneously.
Spontaneously. Well, that anticoagulation is absolutely forbidden.
Okay, thank you.
Okay, if there is no further question from the panel, I'd like to thank you, Dr. Josep Redon, very much for your effort with us today.
Thank you very much, all of you, for your kind invitation.
Thank you.
It has been a pleasure.